Welcome back, kids and coaches, and today we are going to be getting into chapter 15 here, which is the ankle and lower leg. So let's jump right into it. As always with the anatomy here, again, I just want you to have a basic appreciation of it, so you won't necessarily have to know all of the different, anatomical structures here. But what you should know are a couple of the bones that make up our ankle and lower leg. The two that are really the most important here are the bones that are in the lower leg itself, and that's the fibula and the tibia. So your tibia is your shin bone. So that's the one you feel straight on the front of your shin. Your fibula is always on the outside. So it's always outside on the outer portion of your leg. The important thing for us right now is that these make up our ankles. So our tibia or shin bone makes up your medial or middle ankle, so the one that's inside, and your fibula makes up your outside or lateral ankle. The other two bones you should know really from the foot here are the calcaneus and the talus. And that's because they make up either an attachment site for one of our major ligaments or tendons, or they actually form the ankle joint itself. So the talus is the bone where these connect. So your talus actually sits right here in the middle of your tibia and fibula. And this forms what's called the talocrural joint, which is your ankle joint proper. This allows you to bend your foot up and down at the ankle. The calcaneus is important because that is the attachment site for your calcaneal tendon, otherwise known as your Achilles tendon, which is the thickest tendon you have in your body. So those are really the main bone sites you have to know there. And then there's two classes of ligaments, or two sets of ligaments you should know for the ankle. The first one are your talofibular ligaments. You have an anterior and posterior one. Anterior means front, posterior means back. These are located on the outside or lateral side of your foot. So if you notice here, that's your pinky toe, and that's the side that these are located on. Talofibular means they connect your talus to the fibula. Pretty simple. The medial or inside, this is your big toe here. The one you need to know here are your deltoid ligaments. These are important because they're what make up the inside of your ankle. So those ligaments are all important because they make up the inside and outside of your ankle itself. Now the muscles you should know, there's only a couple. You have your gastrocnemius and your soleus. These are your calf muscles. They share a common attachment point through your calcaneal tendon or your Achilles tendon. So those are the ones that are really going to help pull your foot up and push it down. Primarily, what these are going to do is what's called plantar flexion, meaning they are going to let you stand on your toes. That's their primary function. You have really two muscles on on either side of your calf shin area that are going to be important. And one of those here is your fibularis. Fibularis refers to the fibula. It means it's on the outside of your leg. And then tibialis, which is on the inside of your leg. So tibialis attaches to the tibia. Fibularis attaches to the fibula. These muscles move your foot in the direction they face. So tibialis, because this is inside, and hopefully you can get a good picture here. All right, great. So because tibialis runs on the inside, it moves your foot inside like this called inversion. If you put your hand on the front of your shin and turn your foot inward, you'll feel this pop up right at your shin. That is your tibialis anterior muscle. Your fibularis is on the outside, so it'll help move your foot away. If you move that foot away, you'll get it flexing here. And you can kind of see in my foot here, foot ankle area, when I go from relaxed to flexed, how you notice this kind of pops out here a little bit. And that is your fibularis muscle. It's responsible for doing eversion, or taking your foot away from you. Inversion rolls your foot in, eversion rolls your foot away. An inversion ankle sprain that we'll talk about here in a couple minutes is the most common injury you're going to have in sports. Now, when you're doing any sort of testing for an ankle injury, there's a couple you should look at. You have the bump and compression test for fracture, meaning that you're sitting with your foot out, so your leg would be propped up actually. So you know what, why don't I just kind of do this? So my leg is propped up like this. And if I do a bump test, what's going to happen is they are going to hit the bottom of my foot at my heel. And for anyone that's had any sort of leg injury, you know, if you get hit on the bottom of your foot, that is going to send shock waves all the way up. If there's a fracture there, you will know about it. And then there's the compression test. The compression test, as the name implies, you just squeeze it. Because if it hurts when you squeeze it, something's broken in there. And then you would do this external rotation test for any sort of ligament injury. So you would push down on someone's shin here and then take their foot and move it into inversion, eversion. That will tell you, or at least give you an idea if something is injured down there. The other one you have here is this anterior drawer test. So that's very similar to the one that I showed you with the knee, because you're going to do roughly the same thing. You would actually hold on to the shin and you would pull up or push up on the ankle here. So if the ankle were to shift upward, that would typically be a signal that you have a tear in your talofibular ligament. So again, talofibular is the ligament that goes from your talus, which is underneath here, to the fibula. The Taylor or Taylor tilt test, this one now, I would just have my foot hanging out. So my foot would be hanging off the ground, and I would the physician would tilt it or take it into inversion and also to eversion to test there for my calcaneal fibular ligament as well as my deltoid ligament. Essentially, this is the test you are going to do for an ankle sprain. Another one you'll see here are heel toe and rocker tests. So this first picture here is showing the heel test. And what's happening here is this person is, and I'll kind of shift over so you can see my feet a little better. Yeah, actually, I'm going to go the other way so we can keep some light in here. Here we go. Okay. For the heel test, I would be standing up. I would have both feet like relatively close together, and I would shift back on my heels. So my toes were in the air. Now, if you're even just sitting at your chair and you pull your toes up, you'll feel that in the front here, there is a good amount of tension there. If you sit in this position, it's not really that comfortable to lift your toes in the air. If you have, say, like shin splints, or if you have an injury to your tibialis muscle, which is going to cause dorsiflexion, which is bringing your toes up in the air, heels on the ground, it'll show here because you'll see that one foot is lower than the other foot. So in this case, in picture A, you notice that both feet are equal. In picture B, you notice that the back foot is lifted a lot higher. That would suggest that the right foot or the forefoot here has some sort of injury to it or something's wrong with it. Now, if you have, say, a misalignment in your foot and ankle, you would do the toe walk test where you would go up on your toes and you would try to rock back and forward. If you get on your toes and you start rotating outward, that's a signal you have a misalignment in your foot and ankle. Now, as I said, ankle sprains are the most common injury in sports. However, when you hear of the term high ankle sprain, that's really not spraining the ankle. Any kind of sprain is a tear in a ligament. So it's still a tear in a ligament, but a high ankle sprain, you'll see bruising here up on really above the ankle. What's happening is that you have a tear in one of the tibial fibular ligaments. So one of the ligaments that connects the tibia to the fibula. So these are above the ankle itself. Usually with this, it takes about anywhere from about a week to 6 months, depending on the severity. And it's a big severity because if you have a fracture associated with this, so like you break one of these bones, that's where you get closer to that 6-month place. If you just have a light sprain, yeah, usually about a week. Now, these are going to be caused when the foot rotates out and the tibia and fibula rotate in. So what that looks like is if I take this foot, so I'm just going to use this one here, it rotates outward, but my rest of my lower shin is going to move inward. So it's going to rotate inward. And that's very difficult even just to do. So you would be essentially in a position like this. And that's where you're going to get a lot of stress right in that top, just above where your ankle is. Now, the inversion or eversion ankle sprain, this is your true ankle sprain. The inversion ankle sprain, where you roll on the side of your foot, that is the most common injury in sports. So with this, if you take all ankle sprains, this makes up about 70 to 85% of all of them. And about a quarter of these cases will either recur or have pain over a year after the injury. An eversion sprain, where you roll on the inside, is really bad because this can potentially cause like a lot of fractures. It can actually cause knee trauma as well. This is very bad. This is very common. It can be kind of a nagging injury. This here can be a season-ending injury. Now, if you have any sort of tendonitis, remember, is just inflammation of a tendon. So whenever you see itis means inflammation. Osis means failed healing. So tendinosis means that the tendon has failed to heal. Most of these are caused by really just overuse. Not a whole lot of trauma to it, but overuse injuries definitely are going to be the majority of what you'll see with a tendonitis or an inflamed tendon here. Now this here, this Thompson test, this is used to determine if you have an injury to the Achilles tendon. What you'll do is you would have someone like either laying down on their belly or even have them just kind of kneeling on a chair thing, whatever. And you're going to squeeze their calf. What should happen is their foot should point down. If their foot doesn't move when you squeeze, that means that something is wrong with their Achilles tendon. So hopefully I can get myself in a position so we can see this. Well, kind of. Okay. So here is my calf and almost, there we go, calf and ankle. I'm going to try, hopefully be able to do this. Yeah, it's just a little tough here. All right, so if I squeeze my calf, you can very easily see my toe starts to point down. I'm not doing that, that's just what happens. If you do this, so if you kneel on a chair and you squeeze your calf, unless you have an Achilles tendon injury, you will get your toe to point down. So that would be considered a negative Thompson test, which is good. Anytime you have a positive test, it usually means something's bad or something's going wrong. So that's what you would do to test your Achilles tendon. If it's ruptured, nothing will happen because there's no connection between the foot and the calf. So if you squeeze the calf, causing it to contract, because there's no connection there, it's not going to move. If you rupture your Achilles tendon, you cannot walk. The majority of these cases, especially when you get into a grade 2 or grade 3 strain of it, really need surgery. If you have surgery, you typically have a 4 to 6 month recovery process, but only about a 5% chance of re-injury. If you go a conservative route where you do just say physical therapy, about 3 to 4 months, you're shaving roughly 2 to 3 months off of that time, but about a 40% chance of re-injury. Not really the best odds. So usually it's more indicated to get surgery for an Achilles tendon rupture than it is to take a conservative measure to it. Now, again, we've talked about the tendonitis, tendinosis. One other thing here, and we'll talk about this more later, but is how your foot sits. And this can tell you if you're pronated, neutral, or supinated. The majority of people that have anomalies with their feet are going to be pronated. If you have flat feet, meaning your arches collapse. So if you look at my feet, it's a perfect example here. And you know what, let me just get a little extra light in here for this. So if you look at my foot here, I have a tiny bit of an arch, but my foot is pretty darn flat there. Well, when I stand up, what you would notice is that my foot actually will rotate or collapse inward. So it's easiest to see this when you look from behind. So hopefully I can position this so you can all see. All right, there we go. So if you look, my foot looks pretty neutral there. And now when I stand up, you see how it collapses inward. So if I sit down and look at this part right here, so focus right there. Notice where especially this is. That's up. And then when I stand up, that moves down. That is a sign of overpronation in my Achilles tendon or in my ankle. So that's not the greatest thing ever. But if you have flat feet, that is what typically happens to you there. If you have high arches, that's where you're going to get more of a supinated foot. Either one of these is bad, but in a different way. With overpronators, you want to get shoes that offer more medial arch support. So the inside of your foot, you want to have more support going up. If you have too much supination, meaning that your arches are too high, you want to typically get more support on the outside or the lateral side of your foot. Both of these, so if you have your foot going too far or your ankles going too far in either direction, it puts more strain on your Achilles tendon. That's the big problem with it. Now, when we get into really these big, traumatic injuries, we have to definitely look at the fractures here. So remember, the first thing here is that your fibula is non-weight bearing, meaning even if it's broken, you usually don't get a whole lot done to it depending on the severity of it. Your tibia, on the other hand, bears all the weight of your body. So if your tibia is broken, you need to usually reset that. So it usually gets pinned back in place. The fibula usually only gets this if you have more of a complex fracture to it. So if it's something where the bone isn't really disjointed, like it's more of a unionized fracture would be the term for it, then you usually don't get a whole lot done to it. For the most part, you're almost always going to have to get surgery if your shin bone or your tibia breaks. If it's a stress fracture or a hairline fracture, you're talking about 6 to 8 weeks of recovery. If you have to go in for surgery, about 4 to 6 months. So that's kind of a season-ending thing there. Now, if you have a tibia plateau fracture, this here is your knee. This means that you have the top of your tibia, the top of your shin bone gets a crack in it. A Segan fracture is where you get, and it doesn't have to be just with the knee or foot or ankle or anything, but it's wherever you get a fracture, and that's secondary to where a ligament gets pulled off of the bone while still holding on to the bone. So with this, the ligament usually stays intact, but it takes off a chunk of bone with it. So that's where you would see this Segan fracture. With the fibula, like I said, fibula usually only gets major things done to it if it's a non-union fracture. So you look here, and this is a multi-faceted fracture of the tibia, and then the fibula, it looks like it's a bit of a spiral fracture kind of here. But if you notice in the second picture, granted, this bottom screw goes through both the tibia and fibula, but there's nothing done to this fibula fracture because this will most likely heal on its own. Even if it doesn't really put you at any kind of real risk for any future injury or instability there because the fibula is non-weight bearing. If you get shin splints, which I'm sure many of you have, shin splints are just where you get really a pain or almost like a tendonitis in your anterior tibia, your tibialis anterior. So you'll usually get it, on the shin itself, and that just means that the anterior tibia has a strain to it. It's usually something that responds best to conservative measures, so like icing, stretching, resting. But then ultimately, to make sure this doesn't happen again, you want to make sure that you're changing your mechanics, your running mechanics specifically, to avoid this for the future. If you keep trying to run repeatedly while having shin splints, you can actually progress these to the point where you get stress fractures in the tibia. And then a shin contusion, as long as this doesn't have anything to do with a fracture or shin splints, if you just got hit in the shin and it gives you a bruise, there's nothing that that's going to do. You're allowed to keep playing up to your pain tolerance level. And then this last thing here is called compartment syndrome. This is a medical emergency. Compartment syndrome, you have compartments really in two places. You have them in your shins or your calves, and you have them in your forearms as well. When you get compartment syndrome, you get swelling into one of these areas and blood flow stops. Then all of a sudden blood flow begins again. When that happens, you have a potential for getting blood stuck in these compartments. If that happens, you have to get that blood drained, or else you can either lose that limb or potentially die. Um, you got kind of a lot of time, relatively speaking, 3 to 6 hours before tissue death starts. If you don't do anything to this, you got about a 50% chance of dying. So it's very serious. What they do, and by they I mean a surgeon or a physician would do, is they would just straight up cut along the side of your shin or even the side of your forearm, and they just let that bleed out. And that is what you do. This is called a fasciotomy. So you're actually cutting into the fascia that surrounds the muscle there. And that will help to get rid of any sort of blood that gets stuck or is pooled there. Pretty uncommon to happen. You usually hear about this in people that say go from being really inactive to doing some sort of really heavy exercise like a CrossFit or something like that without easing themselves back into it. That's usually what will happen with that. But that is your overview here of the ankle and the foot. And we will be following up here with the rest of the lower extremity, and we will keep moving on from there. So I will see you all later.